Welcome everyone. My name is Yi and I'm your host for the Occupational Medicine Pearls podcast. Today I will be reviewing organophosphate compounds, which are important for any occupational health professionals. They are chemically complex, dangerous to human health, and have a dark historical legacy. Let's start the process. The first question is that what exactly are organophosphates? At their core, they are phosphotriester compounds, and they come in a few different chemical flavors. You'll hear the terms like phosphates, O-phosphorodiurates, S-phosphorodiurates, and phosphorodithyrates, and phosphates and phosphoramidates. Wow, these are quite hard to pronounce, aren't they? However, the key thing is that workplace exposure standard varies depending on the specific compound, and each of them behave a little bit different. So there is no point remembering a single value for the safety limit, but you need to know what chemical you are dealing at your workplace exactly. If we go back in time and look at it, the first organophosphate compound, which is tetraethyl pyrophosphate, TEPP, it was synthesized in 1854. Between 1934 and 1944, about 2,000 agents were synthesized. Some of them were intended for use in the World War II. However, it was never being used at that time. Unfortunately, there were historical events where the organophosphate agents were used to harm other people. Luckily, organophosphate chemicals are very restricted these days. Most of them are insecticides, but some are used as herbicides or fungicides as well. So the risk group is broader than we often think about. And we need to look at what occupations or what type of workers are in the higher risk group. We are looking at the start of the process cycle, so people who are producing them, people who are handling, manufacturing, and transporting the chemicals to the businesses. So that include a manufacturer, formulation worker, and packaging workers, transport, storage, and distribution workers, and people who clean and scrub these containers. After that, we look at the end users who are agriculture and horticultural worker. They would mix, load, and apply the chemicals at their farming. And we need to consider about pest control operators and the veterinary staff because they will be looking after cattle and sheep. The other group of workers we need to be mindful is that seasonal field workers. So it is important that we need to consider all type of exposed work. There are also non-occupational side as well. So people who use home and garden products, and if they are not being careful about that, it can be dangerous. Compounds like diazinon and chlorpyrifos has been widely used by consumers, and we need to be aware of their risk. There are also medication as well. So we need to think about neostigmine, physostigmine, pyridostigmine, certain immunosuppressants, even pethidine. So it is important to interpret the findings of the result of blood or urine when we are assessing these workers. Now we will move to baseline assessment. You can call that as a pre-placement medical assessment. So we need to look at the health of a worker before they starting the exposure-prone work, and we need a solid baseline. So the initial discussion should cover what does the OPs do and what are possible health side effects, how to recognize and report them, and what type of tests and investigation are involved with health monitoring. Afterwards, we'll go into history. So we need to look at past employment history, past exposure, any symptom related to the central nervous system, respiratory system, and GI system, any allergies and sensitization. And with the physical examination, we need to focus on the respiratory system due to the sensitization nature. However, we do not need to perform spirometry at this stage. For biological monitoring, we will collect urinary organophosphate metabolites level, and depending on the exposure, we may need to get baseline blood collection to assess RBC or plasma cholinesterase enzyme levels. If the worker has previous exposure, they should have 2 months exposure-free period before baseline level testing. We take 2 blood samples at least 3 days apart, and they should be within the 20% of the enzyme level between each other. That gives us a reliable baseline. After this, we will need to look at the regular health surveillance or monitoring. The exposure pathway is important. Organophosphate compounds exposure is mainly through skin, although we can inhale the vapor fumes, and accidental or non-accidental ingestion can occur as well. With the biological monitoring, we can use urinary dialkyl phosphate metabolites level. It is not a single compound, but rather a group of 6 metabolites. You can read it up for their details name. And in terms of interpreting them, we can use if based on the urinary level. If the level is less than 100 micromole per mole creatinine, and this is low occupational exposure. Between 100 to 1,000, that is medium occupational exposure. If it is more than 1,000 micromole per mole, this is high exposure level. And there should be a drop in blood cholinesterase level as well. So collecting the timing, the urinary sample is very important, and we are doing at post-shift or pre-shift at the next day. Another way of testing, which is more commonly done, is that blood collection to assess cholinesterase level. That is seen in both red blood cells and outside of them in the plasma. And a drop in enzyme activity can signal early overexposure. Unfortunately, they are not sensitive as urinary metabolites, and we use the 70% of individuals' baseline erythrocyte acetylcholinesterase level as the action threshold. And in terms of the recovery point of view, the plasma cholinesterase half-life can take 6 to 12 days, and erythrocyte enzyme level may take up to 30 days, depending on how our body can produce them. So that's why it is important not to repeat the test too soon. And when do we remove a worker from work? And if a worker is showing symptoms, hopefully not acute symptoms of the organophosphate toxicity and biological monitoring, such as blood shows the significant enzyme inhibition, they should be removed, and they can resume work if they are medically fit to do so. We need to look at the health effects now. We need to understand the physiology of the acetylcholinesterase enzyme first to do so. ACHE under normal physiological conditions break down the acetylcholine at the nerve endings, and it is responsible for transmission of nerve impulses. In the presence of the organophosphate compound, the enzyme is phosphorylated and no longer able to break down, causing acetylcholine accumulation at the parasympathetic nerve synapses. This is at the pre-synapse through muscarinic action, and if it has effects in the motor end plate, they have nicotine-like action, and in the central nervous system through the acetylcholine receptor. So we need to know about the 3 different nervous systems, and the symptom can manifest based on where is the strongest. Usually, the synapses can become overstimulated before they become exhausted. So when we are seeing someone, we need to look at when do they have acute exposure. The tricky part is that different people have different tolerance level, and we can't use the same measurement for every single person, which makes the job difficult. Starting with the effects on the central nervous system, which is inhibition of the acetylcholine receptor. It can cause headache, anxiety, confusion, slurred speech, convulsion, and coma. So they're not very specific symptoms for the nervous system, so I would memorize that as anything could happen. In the peripheral nervous system, that is through muscarinic and nicotinic receptors. With the muscarinic receptor, it will be salivation, lacrimation, urination, defecation, gastric cramps. So it affects both gastrointestinal tract and urinary tract, by increasing the secretions. In the musculoskeletal side, through nicotinic receptor, it can cause cramps, restlessness through stimulation. Now, these symptoms are at the early sign of the exposure. Unfortunately, if the dosage of exposure is high, death usually happens within 24 hours. Now, if a person survives after that period, and then there is a phenomenon called intermediate syndrome, and it is characterized by transient muscle weakness of the limbs, neck, and respiratory muscle that begin 1 to 4 days after a poisoning incident and may continue up to several weeks. There could also be a delayed polyneuropathy as a symptom complex as well. Hopefully, by that time now, that worker has received immediate medical care. We also need to look at the chronic effects with the long-term exposure. To develop the chronic effects, enzyme activity level in the plasma or red blood cell need to reduce from 60 to 25%. That's quite low. Symptoms are very vague. Could be persistent anorexia, which is most of the time we would worry about cancer in a working age person. And there is generalized weakness, ophthalmological effect, change of vision, malaise, and neurobehavioral effects as well. On top of that, many organophosphate compounds are irritant in nature, so they can cause primary irritant dermatitis, although it may also cause allergic dermatitis in the long run. Luckily, there is no clear cause as causing cancer identified among organophosphate compounds. Normally, I would finish my podcast episode here, but with the organophosphates, we also need to know management of acute organophosphate poisoning. It is important as an healthcare provider. So if we see someone with acute exposure, the first thing we need to do is that we need to avoid contaminating ourselves while we are helping that person. They can be readily absorbed through our skin. So we need to wear appropriate PPE that include clothing, mask, and gloves, and eye protecting as well. We need to provide supportive measures, so that will based on the vital stability. And if the worker has a lot of exposure through the nose or the mouth, we need to protect the airways and avoid aspiration. But we also do not do gastric aspiration since they can cause burning effect of the esophagus. And when we are looking at more specific measurement, once we done ABC, we will hopefully that person is already enrolled for ambulance. Chemical agents wise, we need to look at the symptoms. If there is significant bronchial secretion, we can use atropine up to 2 mg IV every 30 minutes, or if the patient is fully atropinized. We can also consider pralidoxime mesylate 1 to 2 gram per IV infusion over 10 minutes for moderate to severely poisoned patients. Hopefully that patient has airway protection if we are needing that medication. We should consider diazepam IV or IM injection based on the symptoms such as apprehension, agitation, or muscle fasciculation. So from the skin contamination point of view, we should remove the clothing of the worker and we need to decontaminate, so wash them off from any residual or excessive organophosphates still remain on their body. After this, the final step for the episode is about controls. We will look at SafeWorks hierarchy of control, starting with elimination. We need to stop using organophosphates if feasible, or use a non-chemical pest management or organic alternative. We have to use at the minimum amount concentration product during the procurement. If we are substituting it, the standard answer is that replace the current one with less hazardous agent when elimination is not possible. But we also need to know what are the hazards that new product brings to the workplace. So we need to evaluate the trade-off carefully. Engineering controls for the airway or vapor control in the workplace is critical. A closed system for mixing and loading to avoid aerosol generation. And we are handling the liquid, we better use pre-diluted cartridges and use water-soluble bags to splash protection. And we should engineer the equipment correctly so that to prevent the backflow to the water sources and to avoid environmental contamination. We should have local exhaust ventilation system or dedicated ventilation system when the the products are handled. That would be applicable to the manufacturing workers. Administrative controls, we are coming down to the lower end of the control system. Having the safety data sheet, a written safety program about the hazards of the organophosphates are important. That should include everything from what to do with the exposure, standard operating manual, you can call that, and how to do the first aid, etc. With the work scheduling to avoid to limit the individual exposure time. And in terms of the clothing, we provide laundry facility and disposable overalls. We consider about training, that's important, safety training, handling of the hazardous chemical, and that training has to be up to date. On top of that, if people are using that properly, there should be a review and audit process for that. And there is emergency planning and drills, how to manage the first aid and in case of acute toxicity. And then we will get to pre-placement medical, where we can make sure that we are screening the right way and the right level of details with the health surveillance. After all this, we'll get to personal protective equipment, which is the last line of defense. We need to consider chemical-resistant gloves, coverall, eye protection, and appropriate respiratory protection. And not only that, if we need to make sure that the workers are using appropriately with fit testing, maintenance, and provision of the replacement for them. That took us a long time, and this is probably the longest episode since I started. I hope this is useful to you, and I will talk to you about a different chemical next week. Have a good weekend. Bye.